please take a seat. We'll move on to the next talk, which will be on heart failure with preserved ejection fraction, a review of management by Dr. K.V. Srikanth.
I'd like to thank Professor Nagraj Desai and Prabhakar Korigal for inviting me. I'll quickly, there is a new guideline I went through recently. It's a very brief guideline which will help all the physicians to go through, primary care physicians to go through. Very concise, all the aspects are covered. And how I would like to discuss about heart failure with preserved ejection fraction, definition, pathophysiology, evaluation, treatment, and when to refer. So we discussed heart failure, the definition, signs and symptoms with structural or functional abnormality. These two are there, plus BNP is elevated, or some, even the clinical evidence of cardiovascular, cardiogenic pulmonary or systemic congestion is sufficient to diagnose. And if you want to diagnose, how do you diagnose heart failure with preserved ejection fraction? You have to have the patient has to fit into the diagnosis of heart failure definition, plus the ejection fraction is more than 50%, and his signs and symptoms are not attributable to any infiltrative cardiomyopathy, hypertrophic cardiomyopathy, valvular heart disease, pericardial disease, or high output heart failure. So these have to be excluded to label somebody as heart failure with preserved ejection fraction. So there are something called heart failure with preserved ejection fraction mimics. Here again the symptoms are there, but we have some other non-cardiac cause like kidney or liver disease which is causing him fluid retention, or there is underlying cardiac cause which we discussed, infiltrative or hypertrophic cardiomyopathy, valvular, pericardial, or high output cardiac. So we just learnt about heart failure with reduced ejection fraction. The primary issues there are neurohormonal activation, direct myocardial injury, and cardiovascular death. Patient die out of cardiovascular disease. However, as the ejection fraction improves, when the EF becomes more than 50, the burden is, the pathophysiological problems are not these things, not the neurohormonal activation. There is microvascular dysfunction, myocardial fibrosis, inflammation, and other comorbidities, and the deaths are not due to heart failure or sudden cardiac death. They are usually due to other conditions. So this differentiates heart failure with preserved EF with heart failure with reduced ejection fraction. Accordingly, the treatment strategies also change. So there is a structural remodeling, hemodynamic alterations, microvascular inflammation, autonomic dysfunction, and cardiometabolic stress or obesity. All of these are the pathophysiological aspects which we have to target. Again, it's almost 50% in the Western population, but it's around 16 to 18% in the Indian and Kerala registry. However, the alarming trend is it's increasing in the West. The reduced ejection fraction is becoming lesser and preserved ejection fraction is becoming more. And in India, probably we are under-recognizing, and hence we are not able to get the proper this thing. And diastolic dysfunction is not heart failure with preserved ejection fraction. If the patient has breathlessness and diastolic dysfunction, please go through him properly, make sure you follow the proper way to diagnose it. And you have to recognize the mimics which are both non-cardiac as well as cardiac. And our aim as a primary care physician should be to identify what are the causes of dyspnea, exercise intolerance, and edema. These are the common things which the heart failure with preserved ejection fraction comes with. So you have to find out if it is cardiac, whether he is having cardiomyopathy, coronary artery disease, valvular, pericardial, or arrhythmias are responsible for his cardiac problems, or if there are any pulmonary causes like COPD, restrictive lung disease, pleural and disease and pulmonary embolism, other causes like anemia, neuromuscular disease, deconditioning, and anxiety. Then again, the edema may be due to lymphatic obstruction or hydrostatic, increased capillary hydrostatic pressure, cardiac, liver or renal failure, or if it is non-cardiac, like non-systemic, like reduced protein intake or protein loss, etc. So everybody should start the diagnostic testing, which starts with ECG, basic ECG echo, to make sure that you are having the EF of more than 50%, and search for other causes, and of course the NT-proBNP. An ambulatory NT-proBNP more than 125 or in acute heart failure more than 300 gives you a clue. If it is less than that, it rules out heart failure with heart failure in general. So how do we, I mean, couple of pathways, how do we approach signs and symptoms of heart failure, preserved ejection fraction, diastolic dysfunction is present. If E by E prime is more than 15 and PCWP is more than 15 at rest or at exercise calculated, or if the E by E prime, the echocardiographic parameter is 9 to 14, you have to have an NT-proBNP of more than 220 or left atrial volume index of more than 34. So this is the Indian recommendation, how do we do? And of course they suggest the heart failure with preserved EF, the scores, which we already discussed, Dr. Ravindranath sir already showed you. So you need an ECG, echo and a clinical history. BMI more than 30, more than 2 antihypertensives, atrial fibrillation, pulmonary hypertension. You give a score, age 60 or filling pressures more than E by E prime more than 9. So ECG, echo and clinical history, clinical examination, there is more than 6 points, you are highly diagnostic of heart failure with preserved ejection fraction. Again, obesity is an important problem because in obese people the NT-proBNP tends to be lesser. There is a more advanced thing where we take multiple aspects of the echocardiographic parameters and the NT-proBNP parameters, and then you go step by step to diagnose, confirm the diagnosis. So you search for non-cardiac cause of edema and dyspnea, apply the definition of heart failure, assess for mimics, and then use the score and conclude the diagnosis. The same thing in a different thing. So investigations can be cardiac MRI, which helps in various aspects, which helps in detection of ischemia and fibrosis. Other cardiomyopathies like non-compaction, amyloidosis, Fabry's disease can be analyzed. Subendocardial or LGE will also give us a clue of this thing. Cardiac CT to see for CAD, which is important, and CT with delayed contrast enhancement gives additional information. It will also tell us about pericardium, lungs and mediastinum, which can give us alternative diagnosis as well as cardiac diagnosis like sarcoid, etc. And if the high risk for CAD, we have to do an angiogram, can include a right heart cath to see the pressures, PA pressures and capillary wedge pressures. Nuclear imaging helps in diagnosis of amyloid or sarcoid, and there are specific protocols. Unless you know which one to order, you should know and then order them. So how do we manage them? So we have to risk stratify and manage the comorbidities. We already saw a slide like that. Hypertension, diabetes, obesity, AF, CAD, CKD, obstructive sleep apnea, all of them have to be addressed. And then non-pharmacological managements, which includes exercise and weight loss, use all methods to reduce the weight, make sure that they lose weight, and there are implantable pulmonary monitors can be used, and again the drugs which I will be discussing. So there are many negative trials which did not benefit heart failure with preserved ejection fraction. They include perindopril, irbesartan, beta blockers, nitrates, digoxin, ivabradine, sildenafil and serelaxin. So if you are considering to use any of these molecules, they will not be beneficial from the heart failure point of view. It may be helpful in managing his blood pressure, it may be helpful in managing his rhythm, atrial fibrillation, etc. So if there are specific indications, use them. Otherwise, these molecules will not help in managing his heart failure symptoms or reducing his burden, disease burden. Diuretics are mainstay, loop diuretics, furosemide and torsemide according to the proper dose. Thiazide diuretics can be added. Be careful when you are using metolazone or that molecule which can cause significant change in the electrolytes. Acetozolamide, if you cannot use MRA, you can use that. And the guideline directed medical therapy, we'll come to that. SGLT2 inhibitors, we already heard. DAPA or EMPO, start at 10 mg, continue at 10 mg. So these are the ones which shows improvement in signs and symptoms as well as reduce your mortality. MRAs, aldactone or spironolactone, 25 mg daily, go up to 50 mg. We already heard how to monitor the potassium and up titrate or down titrate accordingly. ARNI, sacubitril valsartan, start with 50 mg twice a day. Again, you have to see the blood pressure and use it, and go up to 200 mg twice a day. So ARNI up to 56 ejection fraction, up to 57 it has been known to be beneficial. Above that, it's not beneficial. In women, any ejection fraction it's found to be beneficial. Candicertan is another molecule which was shown, long ago. Charm-preserved trial showed that 4 to 8 mg. Probably we don't have it here. I'm just completing for the sake of it. So, a diuretic, loop diuretic, MRA, ARNI, and ARNI-RARB. So these are the 3 molecules, and along with that, SGLT2, which stands at the baseline. So SGLT2 is a basic drug, and MRA plus ARNI. So along with the MRA, which I just discussed, there is a finerenone, which is slightly more expensive, acts slightly differently. The hyperkalemia risks are lesser. It showed in fine arts heart failure trial, EF more than 40. It showed a significant reduction in composite of heart failure events and death from cardiovascular disease, almost up to 18%. So you have 2 MRAs, that is spironolactone and finerenone. So what are the newer drugs? We heard about GLP-1 receptor agonist. Here I think we discussed about oral, but heart failure with preserved ejection fraction trials have all been done with injectables. So we should know that it acts on the liver, kidney, brain, heart, pancreas, muscles. So there was a discussion about sarcopenia and fat cells. So it's a multimodal acting drug, and there is a newer molecule called tirzepatide, which is apart from the GLP-1 receptor agonist, it is also a GIP receptor co-agonist. So it is glucose-dependent insulinotropic polypeptide receptor agonist. So it acts in 2 ways. So tirzepatide has multiple actions by various mechanism of action. We discussed about so many reasons why heart failure with preserved ejection fraction is manifesting, so kind of alters that. So STEP heart failure with preserved ejection fraction trial, in injectable semaglutide, multiple sites, 529 patients, BMI more than 30, EF more than 45, 2.5 mg semaglutide subcutaneous once a week. The studied parameters were KCCQ score and body weight, and it was a positive trial, and SAE was actually lower than the placebo, so around 13%. So it helped in the improvement of heart failure. And tirzepatide, again, almost 730 patients. Here the more hard points were death from cardiovascular disease and worsening of heart failure event. 38% reduction was noted. It was published very recently, and adverse events were mainly GI, almost 6%. So the non-pharmacological management includes weight loss, exercise training, etc. And device-based therapies, CardioMEMS not available, and intra-atrial shunting device has been studied in one of the trials, and it is ongoing trials are happening. So, and these non-pharmacological approaches need trials. So these are the 4 molecules: SGLT2 inhibitors, ARNI, MRA, and GLP-1 receptor agonists. And it acts in multiple ways, and we have to manage the comorbidities. We just saw this slide earlier. There are certain reasons why the patient has to be referred for collaboration, high-risk features, or extensive evaluation which would be needed, cardiorenal syndrome. Because of more analysis of heart failure with preserved ejection fraction mimics increasing diuretic need, and NYHA class 3, similar reasons you need to refer them. So now we have probably, I'm coining a new term, we don't have pillars, we have wheels, constantly changing 4 wheels of heart failure with preserved ejection fraction: SGLT2 inhibitor, ARNI, candicertan, MRA, and GLP-1 receptor agonist. Along with those devices which are still in the process of getting thing, and we need a multidisciplinary approach, because it's not a loss of the myocardium or the pumping failure. It's a multidisciplinary or multi-pathophysiological issue which needs multiple approaches. That I'd like to thank.